Thanks again for joining us for week 6. Next slide, please, Rick. Again, a reminder to avoid, well, actually not to use private health information in your case discussions. Next slide. This morning, I'm going to be presenting, and Dr. Werner and I will discuss the cases. I looked over the cases. Some of them are the questions are very pharmacologically oriented, so I'm going to take the lead on those. And then I was hoping that maybe Kathleen would be here to help, or Karen, but we'll see who we have to also provide some commentary. Amber and Lisa, Dr. Keller will be our presenters this morning. Next slide. If you have any assistance, of course, this is the same reminder as last week. Next slide, please. And these are our disclosure statements. I don't believe there's any new ones at this point. Next slide, please. A reminder once again to use patient-centered language, and you can read these at your leisure. Next slide. Okay, let's get to the heart of the matter. I want to talk about patient empowerment today, which is an important concept. It's an emerging concept, and it's one that I believe very strongly in, having been involved in a number of organizations and committees, such as the National Quality Forum, that really places an enormous amount of burden to improve healthcare and reduce healthcare disparities on the actual provider. And I think I really got turned on to this after finishing a project in Chicago on improving diagnosis of hypertension in children. And, you know, there was some improvement, and we provided clinical decision support, an echo program for the providers, training for nurses on blood pressure measurement, et cetera. But ultimately, when we interviewed providers and other practice staff after the project was over, they said, you know, we'd like to do this, but it's not really us, it's the patients. They are not coming back for their blood pressure measurement, which means we don't have the opportunity to engage with them and to make a diagnosis. So that kind of brought to light the idea of empowerment. Next slide, please. So today, I'd like everyone to be able to define patient empowerment. The definition I can tell you is a little bit abstract, the official definition. Describe empowering patients to seek high quality care for the prevention of cardiovascular disease, and an approach to patient empowerment that you can initiate within a busy primary care practice. Next slide. So let's talk about, first of all, the broader issue of gaps in care that are often highlighted in many reports and on the news, et cetera. For example, we know that among patients who have diabetes and established cardiovascular disease, so these are people at very, very high risk of another cardiovascular event, only 57.9% have controlled blood pressure. And that's not great. You know, when you think about more than 40% of that population is at extremely high risk. Why is it? Is it really because we don't have enough guidance? Of course not. You know, the 2020 hypertension guidelines are very clear. They've been disseminated. They've been incorporated into EPIC. They've been sent around. There's lectures, et cetera. They're hard to avoid. Is it because we have a lack of quality measures and standards and associated provider incentives? No, it's not. Those are all in place as well. Is it because we don't have any innovative models of care, such as complex primary care, the chronic care model, et cetera? No, those have been around for a long time. So certainly there's no lack of tools, programs, and models of care, many of which are linked to financial incentives for physicians for their effective use, available to improve quality, and the lack of such resources cannot explain widespread quality problems in the United States. I wrote this, I don't remember where, but I cut and pasted from something I wrote years ago. Next slide, please. So what are the explanations? Why do we continuously fail to meet quality targets and leave so many of our patients at risk for cardiovascular events in particular? Well, there's the phenomenon of clinical inertia, which is very, very common. So it's the failure to establish appropriate targets and escalate treatment to achieve goals. This is a common thing to which we are all prone, myself included. So a patient comes in with diabetes, their blood pressure is high. It's not my patient. I say, hey, well, when you're going to go back and see Dr. Fredrickson next week, why don't you talk to him? And then Austin sees that patient the following week and he says, well, you saw Dr. Rao the week before. He was probably going to watch you for a little while. And let's not intensify your treatment just yet. And the cycle goes on and on and on. But clinical inertia is often cited as a potential cause of care gaps, but there are some really important criteria that must be met before we declare that clinical inertia is the problem. Clinical inertia is it can be defined basically as the tendency to continue with care that doesn't meet specific standards for whatever reason, because it's the easy way to do things. That's not really fair to most providers. 3 conditions have to be met. There has to be an explicit guideline, okay? And in many cases there is. The physician has to have bought into the guideline. Some of the guideline committees I've been on make, extravagant demands of physicians, especially on the pediatric end, about all the counseling and things you're supposed to do. Well, that's very difficult to implement. That's not clinical inertia. It's just not practical. And the physician has to have the resources to apply the guideline, including time. When those 3 conditions are met and the physician doesn't follow the guideline, we can say clinical inertia is a potential cause or is said to be the cause. Now, clinical inertia is one cause of some of these gaps in care. The second one are patient factors, which are often cited by providers, often quietly. They say, if these patients actually showed up, there would be some improvement. So there are significant disparities in birth outcomes, right? And there's no question that many, many factors play a role, but certainly poor attendance at prenatal care visits has to have something to do with it, for sure. So poor engagement with care is a significant cause. And it can be due to limited interest in self-management, which we see among many of our patients, especially lifestyle modification. So there's not much interest in those factors. And of course, that impacts the outcomes that we often measure. There are, of course, system factors, time and productivity measures. Primary care still remains very poorly structured for management of chronic illnesses such as type 2 diabetes. We are often trying to do the bare minimum, check the hemoglobin A1C, adjust the medications, perhaps do a foot exam, a urinalysis, a lipid profile once a year, encourage the patient to exercise or to eat better, and then we're done. Does it really make a difference? Probably not in terms of self-management and self-engagement of the patients. So let's think about an alternative to some of these explanations and a potentially new strategy. Next slide. So these are some of the solutions. The chronic care model is more than 30 years old, which you don't realize because we've been quoting it in all our research papers and grants for that long period, but it's devised by Ed Wagner. And essentially what it states that is in order to get to improved outcomes, which is the bottom right here, you have to have a number of different elements that need to be engaged. Self-management support for the patient, delivery system design, decision support, and clinical information systems. Of course, those are much more robust than when the chronic care model was designed. The healthcare system and community must support this. All of those things conspire together to lead to productive interactions and improved outcomes. Of course, the system that does this the best in the United States is Kaiser Permanente, that has all of these things. The problem with the chronic care model is that, even though some elements of it have been adopted nationwide, others have not. So Kaiser is a very unique case in the sense it's highly integrated, has a long, long tradition of quality improvement initiatives, has a very impressive research arm, and has had a number of quality champions and innovations. People come from other countries to observe how Kaiser delivers healthcare. That's how impressive they are. Other solutions, one is the idea of shared decision-making, an approach where clinicians and patients share the best available evidence. So I think that it's interesting because this is something we carry out to various degrees in our practices. So patients with diabetes, for example, I can lay out some of the options. You can try to continue with lifestyle changes for a few more months. I can add a medication, but it may make you nauseated. The other factor that I think you need to consider is that we need to consider insulin. Let me tell you about some of the advantages and disadvantages of each. What do you think about that? Let's make a decision together, which is an example of shared decision making. Obviously, it's not the physician entirely making the decision for the patient. That doesn't, hopefully is not happening so much anymore. And it's not the patient just picking an option that they think is convenient or best for them. They have to make an informed decision as to what's going on. Another solution and another phenomenon is patient activation. It refers to a patient's willingness and ability to take independent action to manage their health and overall care. The more activated a patient is, the better their outcomes. More activated patients with diabetes are more likely to perform foot checks, obtain eye examinations, and exercise regularly compared to less activated patients. When a patient comes in and says, "Hey, doc, shouldn't I go back to the ophthalmologist for my retinal exam? It seems like it's been more than a year." That's a pretty activated patient, right? That's very different than some of the patients that we were accustomed to seeing. Or, what can I do to improve my diagnosis? So they are taking a proactive approach to their own care, rather than being a passive recipient of care. What determines patient activation? As you can imagine, it has a lot to do with socioeconomic status and education. So I have a fairly unique practice. We have mostly Medicaid recipients, but I also have a lot of professors and other staff from Case Western and other institutions. And I can tell you, they are highly activated. They will educate me about what the latest developments out there and see, do you think this is something that I can embrace at this point? So I'm sure we all have some of those folks. So education is very, very important. Activation does not necessarily mean a patient who is demanding, which I think is often confused. Just because a patient comes in and says, "I want this," or "Why didn't you put me on this medication?" or "I got these nasty side effects. Why did you do this?" That's not necessarily an activated patient. An activated patient is seeking information and seeking care that will improve their overall health. They're not always doubting the quality of care that you provide. Next slide. So let's talk about empowerment. This is the definition of patient empowerment. I don't especially like it because I think it uses a lot of jargon. It's defined as a means to promote autonomous self-regulation. You think the word autonomous and self-regulation would be intrinsically linked, but this is the definition that they decided. So self-regulation, so the individual's potential for health and wellness is maximized. Now that part seems straightforward. What is autonomous self-regulation? That essentially means that you yourself are trying to adopt changes, make changes, request care that helps you to maximize your health. That's my impression. I see a message from Kate. I think we can redefine it. That would be a better. I would welcome that as well. Let's move on to the next slide. This is the European Charter on Empowerment. We don't have a charter on empowerment here in the United States. That's why I'm putting this one up. This is from the EU. I am more than my health condition, seems straightforward. I'm empowered to the extent I wish to be. I am an equal partner in all decisions related to my health. I have the information I need. My health professionals promote health literacy. I have the ongoing support I need. My experience is a vital measure of healthcare quality. Isn't that a fascinating thing? Our quality measures for diabetes emphasize such things as hemoglobin A1C, control of blood pressure, number of visits attended. What happens if that hemoglobin A1C is well controlled, but the patient is on medications that make them feel absolutely awful? They're throwing up all over the place. Isn't that experience also important? And isn't it intrinsically related to quality? I can participate in evaluating, co-designing healthcare services so they work better for everyone. That's a wonderful and noble aim. Through patient organizations, my voice becomes part of a bigger voice. And equity and empowerment go hand in hand. I want a fair deal for all patients. That's a very important one. So this is an idealistic version. Who are the empowered patients? Of course, they are who you might expect. They are people who are more likely to be well-educated, less likely to be underrepresented or certain minority groups. The biggest, I think, factor that comes into play in terms of empowerment is age. And remember, you think about it, our older populations are the ones who have the highest number of chronic illnesses, and sometimes are the most passive when they receive care. It's the young professionals who come in and say, gosh, I've got diabetes, and what can I do? How can I be empowered to improve my health? So it's a very big challenge in terms of empowering patients across the spectrum and promoting equity. Next slide. So let's talk about racial disparities and empowerment and equity. This refers to non-Hispanic Black adults. And I think, and I was talking to Elizabeth Harris, who's a member of our research team. And what I told her is, and she's looking at health disparities with respect to diagnosis of urinary incontinence, has nothing to do with cardio. And I told her that, don't expect there to be huge racial disparities in urinary incontinence diagnosis and management among older women. And she asked me why. And I said, because as people age, they all get disengaged from care. Nobody gets wonderful care. An 80-year-old white woman, an 80-year-old African-American woman, Latina woman, doesn't matter. They are not going to be terribly empowered, and their urinary incontinence is going to be ignored. So there may not necessarily be huge disparities. That doesn't mean there isn't a problem, but the disparity might not be the focus. Majority of Black adults give positive ratings to the quality of care that they have received recently. And there's not a comparison with the general population, but it's pretty similar. Now, here's something you'll notice. If they are upper income, they generally have a more positive experience. That's true not just of Black adults, but of adults across the spectrum. So where is the opportunity? This, I think, is really important. 40% of Black adults say they've had to speak up to get proper medical care. Does that represent a health disparity? No, it doesn't, because the overall is 41%, which is about the same. And again, you'll notice these are not that different, except for a few issues that are striking. You were rushed by your healthcare provider. Black adults feel less rushed than the overall population. Felt you were treated with less respect than other patients. That's more common among Black adults than the general population, and felt you received lower quality care. This, I think, is our empowerment opportunity when it comes to healthcare disparities, et cetera. Not much difference in weight, et cetera. Overall, not a terrible report, but if there's an opportunity to promote equity, at least from racial equity from this standpoint, it has to deal with treating our patients with more respect and at least the perception that they're receiving lower quality care. This is my specific focus, right? And I've said this many times to people in our department. I want patients here at Cleveland Medical Center to receive the same quality of care that patients in the suburban practices in our department also receive. So next slide, please. So how do we do that? So here's one option, and it deals with that third objective of how do I empower my patients in primary care? Okay, so we developed this 12-question checklist. We have another big project called Empower. So everything is called Empower around here lately. It has a different acronym. And I want to just thank Dr. Kurt Stange. Of course, he's not part of ECHO this morning, but he helped me with this as well. But it's been refined and tested and rolled out many times. It's just not, we don't have the time to study it formally, but it's certainly, you're free to use this questionnaire if you wish. So what it is are 12 questions that any patient with diabetes, regardless of their age, race, ethnicity, sex, anything of that sort, should be asking of their provider. And what it is it is activating the patient, but these are all things that they are entitled to. One of the approaches of promoting health equity that I've always embraced is that everyone is entitled to the highest quality care, okay? If that is true, the fact that somebody in the suburbs is getting an SGLT2 inhibitor or GLP-1 agonist, assuming coverage is even across the board, and that's of course a separate issue altogether, you should also be able to get it. If they can get their flu shot in their office, you should also be able to get it. If they're getting counseling about physical activity and dietary changes, why should you not be eligible for that at all? Why should you not receive it? So these are the 12 questions. Has your doctor discussed improving control of your diabetes? Often we don't We just kind of stick to the status quo when it's not controlled. Has they talked about adding or changing medications, about medications for preventing heart disease, your blood pressure, your cholesterol, exercise? If you smoke, they even mention quitting smoking. Has your doctor checked your urine in the past year? Have you had your eyes checked? Have you been offered a flu shot? And here are the two questions that Kurt suggested, which come from, Kurt Stange suggested from another quality measure. This is really important because, you know, a lot of our quality measures are discrete. You know, did you get an eye exam? Did you get your hemoglobin A1C? Did you get your lipid panel? But how about, does your doctor know who the most important people in your life are? That's really important, right? And I do, you know, I may not know, but I often write something down in my notes, you know, son going off to college. So the next time the patient comes in, I can say, how is your son liking college? I can tell you that is a great way to build rapport. In caring for you, does your doctor consider all the factors that affect your health? Now, why do we ask patients to complete this? Is it for them to realize, hey, wait a second, I don't have a very good physician or a very good provider because I am answering no to 7 out of these? No, that's not the whole point at all. It's to make the patient aware that these are the sorts of things that their provider should be providing to them in a typical diabetes encounter or over the course of a year, which is what we recommend here. You're not going to do all of these things all the time, right? It is empowering. The second question that comes up is this not intimidating and unmotivating and discouraging to the providers if a patient comes in with this worksheet and says, gosh, wait a second, you didn't send me to get my eyes checked this year? Well, the evidence actually shows something quite different, that when you have an empowered patient, the encounter is more meaningful and more rewarding, not just for the patient, but for the physician as well. And instinctively, those of us who care for patients probably have this in mind. When a patient comes in and says, hey, doc, what was my HDL cholesterol on that last lipid panel? And you're like, wow, okay, let's talk about that a little bit. And here are some of the things that you can do to improve it. That is much, much more rewarding for me personally than someone who's very passive or disengaged with their care. Again, the driver here of empowerment in this case is not you need to do a better job with your care. The driver here is you as a patient are entitled to the highest quality care, regardless of what your background is and where you come from. And that's the perspective I think that we need to promote with our patients. Now, this is a worksheet. You can hand it out or you cannot. But there are other ways in your day-to-day practice that you can be more familiar with the empowerment concept. Next slide, please, Rick. So here are some questions, and you guys can devise your own. There's a limitless number of these. This is one I talked about yesterday. I think I've given so many talks this week, I've forgotten where I was, but yesterday I was speaking about this. So what questions do you have about your visit today? That's the way to ask that. Don't say, do you have any questions? Any questions? You know, I think the surgeons are pioneering this approach. So, you know, when you do a consent, you're about to do a complex procedure, and you explain all kinds of details that are complicated and lengthy, and it's a big discussion. You know, the wrong thing to say is, any questions? Are we done? Okay, sign here. That's not a good thing to do. Most people will sort of passively say, I guess not. But when you ask, what questions do you have? I'm sitting here waiting for you to ask me questions because I'm pretty sure you have some, right? And they may be things I've already explained. They may not be, you know, they may be things that I might not be able to answer, but I want you to be empowered to ask questions. What do you believe you need to better manage your diabetes? Boy, that's a really different way than asking, here's what you need to do to better manage your diabetes. I need you to take your medication on time. I need you to go to the dietitian. I need you to go to the eye doctor. No, that's not empowering a patient. What do you believe you need? Okay. You know, you're managing diabetes, which takes a lot of effort. What can I provide for you to help you to get there? Okay. How can I help you achieve your goals? Very, very different than saying you need to be more consistent in taking your medication. So patient comes in and says, you know, did you take your metformin? I miss, you know, pills quite often, or I forgot to refill it, or I went on vacation, I didn't take the medication. Now I started taking it again. Okay, well, you know, if the goal is for you to take your medication consistently, How can I help you achieve that goal? What can I do to help you? And this actually, I did this quite recently. This gentleman, we asked him to put his metformin by his toothbrush every morning because he brushes his teeth every morning. That worked for him. So those are the kinds of things that actually empower patients. It is quite a different approach. Of course, it is closely linked to shared decision-making and patient activation. And it is a complement to a lot of the things that we do on the provider end. This curriculum, for example, is a provider education program. Quality measures, incentives, incentive payments, clinical decision support, all of that is complementary to it. But you will not achieve the outcomes you hope for in your patients unless they are empowered. I think we got to go back to Claire for a moment to wrap up.
Yep. Thank you. So just a couple announcements. Cardio has a webinar coming up in November. If you'd like to attend, the QR code there, or you can go to our website. It's on COVID-19 and cardiovascular health. Rick, next slide. And then you all are the first group to see this, very exciting, but we are officially opening registration for the Spring Echo. But it's starting in January. So it's going January 12th through March 30th. Innovations in diabetes and cardiovascular health. We do encourage repeat participants. So if anyone would like to join us again, we would love to have you. And then also if you want to send along to any colleagues that you think would like to join, I will also be sending an email with all this information on Monday morning. But the registration is live now on our site. So any questions, just let us know. Please fill out the post survey that's in your mailbox or should be in your mailbox. And we will see you all next week.
Okay, thanks, everyone. Have a good week. Bye-bye.